Let's assume one clinical scenario. You are in emergency department and one 50-year-old female without any prior comorbidities presented with history of syncope. So she had syncope 1 hour back at home and she is currently fine. Her vitals are stable, GRBS is normal, oxygen saturation is normal, all investigations are normal. You did ECG, and in ECG what will you look for to find out whether there is conduction abnormality of the heart or structural abnormality of the heart that is causing low perfusion to the brain. So let's first of all talk about conduction abnormalities. So in conduction problems, what are the things we will look for? So definitely we will look for intervals like PR interval, whether PR interval is less than 120 millisecond or more than 200 millisecond, then QRS, then QT. So whether QRS is broad or not, like more than 120 millisecond in bifascicular block, or you can say if right bundle branch is blocked and left anterior fascicle is blocked, or left posterior fascicle and right bundle branch is blocked, then in that cases also in bifascicular block, that kind of patients generally can go into complete heart block episodically. So when you see ECG, you might see bifascicular block, but that patient intermittently can go into complete heart block. So that's why you have to pick up bifascicular block. So you look for QRS, and then QT, whether QT is more than 450 millisecond or less than 340 milliseconds. So these are the intervals that you will analyze. And apart from intervals, what are the things we will see? Another is ST segment, to look for Brugada pattern. Although there are very few cases in our part of the world where I am currently working, so I have seen very few cases of Brugada syndrome. I am not a cardiologist, definitely cardiologist might have seen more cases, but as far as I am aware, I have seen very few cases, and one case of type 1 Brugada syndrome I saw a few days back. So definitely you have to look for ST segment elevation in V1, V2, V3 and T wave inversion, or whether it is biphasic T wave or upright T wave. So that is ST segment. And another is epsilon wave. So just after QRS, if there is epsilon wave or not, because in arrhythmogenic right ventricular cardiomyopathy, where there is replacement of right ventricular myocardium with fatty tissue, fibrous tissue, you can get epsilon wave after QRS. So you have to look for that. So QRS, then ST segment and epsilon wave. And now talking about a structural problem of the heart. So in a structural problem, you have to look for hypertrophic obstructive cardiomyopathy and aortic stenosis, which you can pick up with ECG as well. You don't have to do echocardiography, like you have to confirm with echocardiography, but definitely if you see features of left ventricular hypertrophy in ECG, you know the criteria of LVH in ECG. So if you see ECG and if you see typical dagger shaped Q waves, then that definitely suggests. So LVH suggests that there might be HOCM or there can be aortic stenosis. Now let's come back to intervals and let's talk in detail. So let's start with PR interval. So if PR interval is short or long, you have to look for. Like let's say PR interval is less than 120 millisecond, like it is 100 millisecond or 90 millisecond. So what can be the problem if PR interval is short? it means that the impulse that is originating from the SA node is not going through AB node, because if it goes through AB node, definitely there is some pause. So there should be like at least 120 millisecond interval between P and QRS. But if there is bypass tract, and you know bypass tract does not have any AB node, so impulse directly goes from atria to the ventricle. So the PR interval is less than 120 millisecond. That we call pre-excitation syndrome, and one of the popular example of, you can say, pre-excitation syndrome is WPW syndrome. So look for that, because if there is WPW syndrome, pre-excitation syndrome, then if patient episodically develop atrial tachycardia, atrial arrhythmia, then those all impulses can go through the bypass tract, and it can cause ventricular tachycardia as well. So that is short PR interval. Now if there is long PR interval, like more than 300 millisecond, if PR interval is between 200 to 300 millisecond, I have not seen any cases of syncope with that much length of PR interval, like 200 to 300 millisecond, but definitely syncope can occur if the PR interval is more than 300 millisecond. And you also look for second degree heart block, because if there is second degree heart block, like PR interval is prolonged and there is also missing beat, then during those missed beats there can be syncope, or if there is complete heart block. So that basically suggests that AV node is degenerated or infarcted, and the conducting fibers that is coming from the AV node, like bundle of His, and so whether the bundle of His is degenerated or not. So these heart blocks gives idea about AV node and the bundle branches, whether they are intact, conducting or not. So you look for that. Then let's talk about QT interval. So if QT interval is more than 450 millisecond, let's say, like if it is 510 millisecond, if QT interval is prolonged, what do you understand by that? It means that ventricle has depolarized, but it is taking more time for repolarization. So TE wave is coming late, right? So ventricle has depolarized, it is contracted, now it has to be repolarized to begin another cardiac cycle, but repolarization is slow, it is occurring late. So if there is late repolarization, in between there can be chaotic ventricular beats, and that can cause torsades, right? Or if QT interval is short, let's say if it is less than 340 milliseconds, let's say it is 300 milliseconds, let's assume. So what does short QT interval mean to you? It means that ventricle depolarized and repolarization is occurring too early. So if repolarization occurs too early, then there is also chance of ventricular arrhythmia. There is chance of ventricular arrhythmia, and during those episodes there can be syncope. So you look for QT interval. And I have already talked about QRS interval. If QRS is wide, like let's say if it is more than 120 millisecond, then there can be bifascicular block as well. So you have to look for bifascicular block. I have talked about ECG interpretation of bifascicular block in another video. You can check that, but definitely look for bifascicular block. This video will be very long if I go on talking everything in detail. So that is about QRS. And I already talked about Brugada pattern. You will have to look for Brugada pattern. You have to look for epsilon waves or not, and you have to look for structural abnormalities of the heart, like if there is left ventricular hypertrophy or not. So these are the basic things you have to look for in ECG when you are analyzing ECG in a patient with syncope. And there is very popular mnemonic of to remember this in emergency department, because we forget something when we are doing some work, when we are in rush, then we might forget, and so we have mnemonic for it. And I think the mnemonic is OBBLE, WOBBLE, OBBLE. You can search on that. So W stands for WPW syndrome. So look for WPW syndrome. O for obstructed AV pathway. So obstructed AV pathway means look for PR interval, whether it is greater than 300 millisecond or not, or whether there is second degree heart block, third degree heart block. And B for bifascicular block, and another B is for Brugada, and L for left ventricular hypertrophy. So look for amplitude of QRS in V1, V6, and compare whether there is left ventricular hypertrophy or not. There is different criteria to diagnose LVH. If you might know those things, like if you see S wave in V1 and R wave in V5, if you sum those, if it is more than 35 mm, so this is one of the popular criteria to diagnose LVH, and definitely there are others, so you can look for that. And E for epsilon waves, and R for repolarization abnormality, like long QT, short QT. But I am generally not a fan of mnemonic, because I forget mnemonic. So what I do, that I look for PR interval, I look for QRS interval, I look for QT interval, I look for Brugada pattern in the ST segment, I look for epsilon wave, and that is about conduction system, right? So disease of conduction system. And another, I think, if there might be structural abnormalities, so the common structural abnormalities causing syncope I know is HOCM, aortic stenosis. So that's all.